afternoon, everyone. It's a pleasure to be here. My name is Edina Tari, and I'm a first-year PhD student and a first-year gastroenterology resident at the Institute of Pancreatic Diseases. My supervisor is Bálint Erős, and my SMS is Anatrans. My vision is to improve patient care in acute gastrointestinal diseases, and my mission is to conduct high-quality researchers in the same topic. Currently, I have two ongoing projects. My first project is about investigating the influence of papilla morphology on ERCP outcomes and adverse events, which is a meta-analysis and a systematic review. And my second project is about the early care of the hemodynamically unstable gastrointestinally bleeding patient, which is a feasibility trial for an RCT. So let me talk first about my first project more detail. So, ERCP is the most common therapeutic procedure for pancreatobiliary disorders. However, how to best achieve a safe and effective bile-duct cannulation is still a debated question. Endoscopists doing ERCP routinely often recognize a difference in the macroscopic appearance of the papilla. This has led to a conception that certain appearances are more difficult to cannulate and therefore more prone to adverse events. The first validated classification of the morphology of the papilla was published by a Scandinavian research group in 2019. They differentiated 4 types, and they found that certain types were more difficult to cannulate, and in those types the incidence of adverse events were higher. Our aim is to determine the influence of papilla morphology on ERCP outcomes and adverse events. So, our clinical question is then, how does the morphology of the major papilla affect bile-duct cannulation outcomes and adverse events? Our conditions were difficult cannulation, cannulation failure, cannulation attempts and time, and the event rate of post-ERCP pancreatitis and the other post-ERCP adverse events in the context of the papilla morphology in adult patients undergoing ERCP with a native papilla. Our hypothesis is that certain morphologies can predict a more difficult cannulation and a higher rate of adverse events. So we conducted our systematic search in 3 databases at the end of September with the following search key. Almost 7,000 articles were identified, and from that 36 were eligible for full-text selection. Finally, 17 articles could be included in the systematic review part and 13 in the meta-analytical calculations. So today I would like to present you 2 of my forest plots. In this forest plot, you can see the pooled event rate for difficult cannulation in the different papilla types. This is a clinically relevant and important question because the higher the rate for difficult cannulation, the higher the chance for developing the different adverse events. You can see that the heterogeneity was high. Several reasons could be behind it, but I think one of the most important is that there were some difference in the definition used for difficult cannulation in the different studies. So in the forest plot, you can see the pooled event rate for difficult cannulation for the different papilla types below each other. For example, in type 2 papilla, it was 0.39, which means that endoscopists, in case of type 2 papilla, will experience difficult cannulation in 39% of the patients. In the forest plot, you can see that in type 1 papilla, the pooled event rate of difficult cannulation was significantly higher compared to the other papilla types, which means that the differentiation between the type 1 papilla and the other morphological variants is clinically relevant. And this can lead to one of our implications is that endoscopists during their ERCP training should start with type 1 papilla. And you can see that these results were not actually statistically significant, but the p-value refers for a higher tendency. In the second forest plot, you can see the pooled event rate of post-ERCP pancreatitis in the different papilla types. The forest plot is actually the same. You can see that in this case, total homogeneity was observed. And this question is important because post-ERCP pancreatitis is the most common adverse events of the ERCP procedure, and it can be associated with higher mortality rate. And you can see that the pooled event rate of post-ERCP pancreatitis was higher in type 2 papilla compared to the other morphological variants, which means that patients with type 2 papilla should be monitored more closely and carefully for developing post-ERCP pancreatitis. And you can see that these results were actually statistically significant. So there are many strengths of our meta-analysis. For example, a comprehensive search was done with a rigorous methodology, and most studies carried the low risk of bias. However, there were some limitations. For example, as I have already mentioned, there were some difference in the clinical definition, and as we included mostly cohort studies, the evidence was low or very low. So in conclusion, differentiation between the different papilla types is clinically relevant, since certain morphologies can predict a higher rate of difficult cannulation and post-ERCP adverse events. And some of our implication for practice and research is to try to use a unified classification system to promote transparency throughout clinical practice and future researches. And trainees should start their endoscopic practice with type 1 papilla. And actually, the manuscript is written. It was sent out for internal review, and I'm happy to say that it will be presented next month in Dublin as an oral poster presentation in the ESGA days. So let me talk about my second project briefly, which is about the early care of the hemodynamically unstable gastrointestinally bleeding patients, and which is a feasibility trial for an RCT. So acute gastrointestinal bleeding associated with high mortality and rebleeding rate, especially when these patients develop hemodynamic instability. However, the recommendations in the current guidelines regarding these patients' early care is insufficient. We conducted a systematic search, and we could identify only one RCT which assessed vasopressor use in this population. They included gastrointestinally bleeding patients in the state of shock and requiring ICU care. And in Arm A, these patients received limited fluid resuscitation combined with HASH and vasopressor use. And in Arm B, they received the conventional fluid resuscitation. And you can see that the resuscitation time was significantly lower in Arm A, who received the limited fluid resuscitation combined with vasopressor. So our plan is to conduct a feasibility study with 10 patients in both arms for an open label 2-arm RCT with a superiority study design. We would like to include hemodynamically unstable patients with an acute gastrointestinal bleeding episode, and in the intervention arm, they will receive a combined fluid and vasopressor resuscitation combined with a standard fluid resuscitation, and our primary outcome will be the resuscitation time. And in summary, I would like to submit my first project in the next month, and regarding my second project, I'm waiting for the article approval, and then I would like to conduct the feasibility study later this year. So thank you for your attention, and I would like to close my presentation with a quote from Nikola Tesla: "Let the future tell the truth and evaluate each one according to his work and accomplishments. The present is theirs, the future for which I have really worked is mine."
My question is regarding to one of your first plot. You mentioned that the difficult cannulation was described in not in one way in the articles. So what was the differences between them?
Yeah, actually most of the studies use the ESGA classification for difficult cannulation, which means that more than 5 attempts or more than 5 minutes or cannulating the pancreatic duct at least 2 times. But the study of Tungzuan et al. Used the definition excluding cannulation time.
I'm curious regarding your second project. Congratulations for the presentation.
Thank you.
How will the group with the low-dose epinephrine or vasopressor therapy receive fluid management. Will they or won't they receive any, or a lower dose?
They will receive, actually in the feasibility trial, they will receive the same amount of fluid, but in Arm A they will also receive vasopressor, and in Arm A they don't, and we expect that the amount of the infused fluid will be lower in the intervention arm because the resuscitation time will be lower.
I would like to ask a question regarding to your first project. Did you use any classification method for the papilla morphology?
Yeah, in every outcome we conducted two analyses. The first analysis, which I presented, was only studies using the Haraldson classification, but we also tried to group the other classification system based on the imaginary of the studies and the description of the morphology.
What kind of patients with acute GI bleeding do you choose for your feasibility study? Lower, upper, ulcer, variceal?
All of them.
Okay. And one another question regarding to your first project. Okay. How homogeneous was your population regarding post-ERCP pancreatitis prevention? What kind of medication or fluid or what they get?
Actually, most studies don't detail this question, the prevention for post-ERCP pancreatitis, because most studies were cohort studies assessing the risk for post-ERCP pancreatitis, but they don't really detail the prevention strategies.
That could be a limitation then.
Yeah.
Now I'm also working on a project regarding hemodynamically unstable GI bleeders. I want to ask, what is your definition of limited fluid resuscitation and conventional fluid resuscitation? Is it the same as restrictive and aggressive fluid resuscitation?
In the RCT, like there were for example, blood pressure value which should be
Maintained,
yes. And the CVP value and like a urine output value too.
Okay, so it's not actually the rate of the fluid,
no.
it's maintaining the systolic blood pressure.
Yeah.
Okay, thank you.
If I got it correctly, there will be patients enrolled with GI bleeding who are hemodynamically unstable. Do you wish to do a crossover in case of patients who do not respond to fluid therapy alone?
In the feasibility study, no, if they don't respond, that will be a safety criteria that they will be excluded and they will receive vasopressor.